So you'll see a little consent form come up on your screen that you consent to you being here and recorded. So just some quick housekeeping notes. If you can make sure that you're muted. So just make sure you hit the mute button there. And we will, throughout the presentation, be monitoring the chat box. If you have questions, you can throw them up there. And as well, I'll pause throughout as needed to address those, and as well at the end of the presentation. So with all that being said, please welcome Dr. Lyle Thomas, your presenter for the day. And just want to say a huge thank you, Dr. Thomas, for being with us today. This is probably our #1 most requested education topic. Number 2 is pediatric DKA, which we're going to be working on for the new year. So really grateful that you're here to lend your experience with us. And with that, I'll let you take it away.
Great. Thanks, Natalie. Thanks for having me. Hopefully you guys can all hear me here. Yeah, happy to come and talk about DKA. I'm just going to get the presentation up on the screen here. Change that. There we go. Yeah, this is a talk, that I've given hundreds of times over the years, and happy to do so for docs, for nurses, for anybody who'll listen. I've given this talk, and mainly, over the years, not a whole lot has changed with DKA. Except most recently with Connect Care. Obviously, that's made things a little more difficult. But if anything, Connect Care has just sort of made my point as to why I do this talk, is that DKA is a complicated disease, and it's a fluid disease where things change quickly or slowly. Both the long game and the short game are important. Connect Care is not ideally suited for that kind of thing, and so it's going to have its challenges unto itself, but it reinforces the point that it is extremely important that everybody involved actually understands what's happening in DKA. We always talk about healthcare being a team sport, a team model where we all work together. I've long said the place that happens the most is in the ED, where doctors, nurses, pharmacists, OT, PT, home care are working as a team all the time. But from a disease point of view, there's not many more where this is important than in DKA, because everybody needs to know what's happening. They need to understand what's happening, not just following orders, because that's when things go awry. You need to understand what's happening. You need to know why you're being asked to do a certain thing, even though we all have different roles in this. You have to understand not only why you're doing something, but why I'm asking you to do something. And that's super important. And that's, I've definitely, in our department here in Red Deer, empowered our nurses as much as possible to learn about this as much as they can, to understand it. They ask me questions all the time. And I encourage them to go to the docs and say, listen, I'm not sure that this should be going like this. And shouldn't we be doing this? And shouldn't we be doing that? Why? Because they understand what's happening. And hopefully in this very short hour, we're able to come to that same sort of understanding. So we'll go through it. We're going to go through the diagnosis very quickly. We're going to go mainly through the treatment. We'll look at a few cases of things that have gone bad. And if we have any time left over, we'll try and look at maybe the paper copy of the chart to see how it flows and how it correlates with this talk. I will stop at certain sections for questions, but yeah, if there's others in the meantime, please just enter them into the chat box. Unless they're absolutely burning questions, then go ahead and interrupt. And again, if we can make sure everybody's on mute, that would be great so that the screen doesn't flip over. All right, so let's get going. This is a diagram. Like I said, I've given this talk for years. This slide is now coming up on 20 years old from the CMAJ, but really it's just a reminder. We're not going to get too much into this of the pathophysiology, but just a reminder of what we're dealing with. If we're gonna understand everything, we have to know the pathophysiology and what happens. So if we look on this side here, this is the DKA side. And as you guys know, there's an absolute deficiency of insulin, meaning there may be sugar in your blood, but insulin, which carries that sugar into the cells so that it can be used properly, is not there. So basically your cells start to starve and they look for an alternative source of energy. They're looking for another way to get energy. And what ends up happening is your body breaks down adipose tissue, fat tissue, okay? Which sounds like a good idea in principle, and it is for certain diets and things like that to a point, but at some point it becomes pathologic. Basically your liver converts this adipose into marginally usable energy, not as good as carbohydrates, not as good as the glucose, but it does do that. But the problem is it comes out on the other end with waste material that we do not want, which is ketone bodies that lead to all the problems of DKA and acidosis in general. So this is what we're fighting, guys, and keep this in mind. This is what we're fighting. Our body has decided to switch metabolism from a glucose-based one to a fatty acid based one, where they're breaking down material inefficiently and creating byproducts that are not good for our body. And that is the crux of DKA. So why do we care about DKA? This is the royal we. Why do we care? Well, because it's still fairly prevalent. So these are numbers from a number of years ago. I don't know where they are exactly now, but they're not a whole lot different. So that stat just says we see a lot of DKA. Okay, 5,000 to 10,000 patients a year are admitted for DKA in Canada. Okay, and still, despite all we know, there's still a fairly significant mortality rate between 4 and 10%. So again, that's the royal we. So my question always, I'm a selfish kind of guy. Why do I care? Like, and why should you care in particular? Well, the last thing that I put up is why you should care, right? There's a mortality rate of 4 to 10%, which is obviously significant. From an ED perspective, I'm speaking from an emergency department perspective, half of those deaths occur early in the first 48 to 72 hours. Well, that's where I'm involved, right? In those first hours. I would like to say I'm only involved in the first 6 hours, but those of you who work in an ED know that we're often involved for 24 or more hours as the patients in our department. So not only is there a high mortality rate, I am involved in the early part of this disease where a lot of that mortality begins. That's why I care. This is not somebody else's problem. Okay, so let's kind of quickly go through diagnosis before we get to treatment, which is where most people's questions lie. So how do we diagnose DKA? Well, they kind of give us a hint, right? They've given us 3 parts to this: diabetic, keto, acidosis. So not a hard stretch to figure out how are we going to diagnose this. Well, number 1, there's usually hyperglycemia. Okay, so their sugars are high. Usually over 14. So what makes this a bit of a challenge? I told you everything in DKA is a challenge. What makes this a bit of a challenge? Well, it doesn't have to be high. Okay, most 90% of the people that we see are going to have a high sugar, and that's going to give you a clue, but it can be lower or normal, or what we call euglycemic DKA. And that can happen for a number of reasons. More recently, is the introduction of new medications, the SGLT2 inhibitors, and they can actually create DKA within normal while still maintaining your sugar. Okay, so it's a bit of a challenge. You got to keep your eyes out. You got to be looking for it and being worried. The other part that tends to trip us up in the ED and elsewhere is that in people who are newly diagnosed with diabetes, 50% of them present in DKA, meaning they don't know they're diabetic when they show up. They just feel terrible. Okay, they're coming in the emerge because they feel awful. All right, you know all the signs and symptoms. They have polyuria, polydipsia, blurry vision. Maybe they tell you about that. Maybe they don't. A lot of them look like they have the flu, and especially in this flu season that we're all dealing with now. There's a number of people that come in that people say, oh, well, you got the flu, go home, take some fluid, take that. Why? Because the patient doesn't know that they're diabetic, and they didn't tell you that they're diabetic, so you didn't consider it. So you definitely need a high index of suspicion to even check their sugars and decide that they might be a DKA. So that's a sugar part. How about the ketones part? Okay. Well, ketones, we know we're looking for ketones. And for a lot of us, especially if any of you are working in really rural places, the only thing that you have is a urine dip. And you can see, a lot of complicated numbers there, sensitivity and specificity and negative and positive predictor value. The thing about this stat is basically saying that urine ketones are a good measure to rule out DKA. If you want, if they don't have ketones in their urine, they're not likely in DKA. However, it's not very specific. And the reason being is that it's measuring acetoacetic acid or acetone. That's the ketone that urine dips are looking for. And that's not specific to DKA. That can come from a number of reasons. And so the presence of urine ketones doesn't necessarily mean that they are in DKA. The absence of urine ketones rules it out for sure, but we would rather use something called beta hydroxybutyrate. And that is a serum test, a blood test, which has a much higher specificity. You see about 80% there, meaning if you actually have beta hydroxybutyrate, then they are most likely in DKA. All right. This unfortunately is not available to everybody though. The last thing is acidosis. So again, typically these patients are acidotic. Their pH is less than 7.3. What makes this tricky? Well, their pH might be normal. Okay, if you actually do an ABG or a VBG, you may actually get a normal pH, and that's often due to a mixed acid-base disorder. If they present a little bit later and they've been vomiting and vomiting and vomiting, they get a metabolic alkalosis, which balances off their metabolic acidosis. Or they're breathing real fast and they're able to compensate early and they're not acidotic. So we got to be careful with that. The way that we can do that is we're checking the anion gap and we're looking at their serum bicarbonate, which is going to be low. Okay, so don't get tricked by necessarily a normal pH. Quickly pop this up. This is just Canadian Diabetic Association guidelines as to what you need to diagnose DKA, and they're mainly things that we just talked about. You obviously need their glucose, you need their electrolytes for a number of reasons. One, to collect their anion gap. They asked for urine and serum ketones, both needed to diagnose DKA. That is not possible everywhere. As a bottom line, if you're in a place that cannot quickly get serum ketones, if they look sick, they have high sugar, and they've got positive urine ketones, it's DKA until proven otherwise. One thing really to remember is the underlying cause. So while we diagnose and treat DKA, we got to remember that there's often a precipitating cause to this, and they can be serious things like sepsis, MI, stroke. And so any other tests that we need to help us diagnose and manage those conditions are really important. If any of you do work in an ED, even those on the floor that work will know this. The number one reason for DKA is non-compliance, right? So we have a lot of friends in the ED that we know very, very well that just repeatedly come in DKA because they don't take their medications. And we know their story, we know all about them, and we see them often. Exchange Christmas cards. Okay. So any question, I'll take a quick break there. Any questions on the diagnosis of DKA? Isn't usually many, it's pretty straightforward. Okay, so let's get on to the management.
You have one question pop up, yep.
One in there. Is there a reason docs wouldn't measure the anion gap? Because they're terrible at math. That's why. That's why we wouldn't do it. But no, there's no reason. And in fact, in most places, if you order electrolytes, they automatically calculate the anion gap and give it to you. Osmolar gap's a different, whole different beast where you got to do a lot of math, but the anion gap shouldn't be a problem. If you order electrolytes, the anion gap is presented to you. All right. So on to the management of DKA. Now, here's where most of you have tuned in for this, for questions and how to do so. And like I said, it is very complicated. It is very fluid, and things shift and change on the fly. And so, when I teach this, especially to my residents, but to nurses and everybody else, I always bring up this analogy. One of the other things that scare people, that get them a bit nervous when they're working in the ED is trauma and a sick trauma patient, and things can get wild and woolly pretty quickly in a trauma room. A lot of action, a lot of people, a lot of blood. The one thing about complicated diseases in the ED and anywhere else that I stress to my residents to learn is the more complicated things are, the more out of control things seem, the simpler you need to think. Okay, you need to simplify your thinking to the most basic things, and that's how you're going to work your way through, get through, and obviously give a good outcome to your patient, hopefully. Okay, and then one of the biggest examples is trauma. So I mentioned DKA being a team sport. Trauma is obviously also a big team sport in the room at the time. And despite that chaos and all those people together, all of us kind of learn a very simple algorithm for trauma, and we start with it all the time, ABCs. So this should be familiar to all of you guys. As an emerge doc, it's super simple. I'm a simple guy. This is the way I think in very simplistic terms, airway, breathing, circulation. Three things that we all think of as we enter the room. And we're also taught not only about airway, breathing, and circulation, we're taught to think of them in that order. Okay, that's how we should be approaching the patient. First, the airway. Is their airway okay? Only once I'm okay with the airway do I then go on to breathing. Make sure the breathing's okay. Once I've gone on with the breathing, then I go to the cardiac or circulation portion of it and deal with it. And if ever there's a problem, I go back to the top and I reassess from the beginning. A before B, B before C. Now, in real life, that doesn't always happen. Often we have to jump and deal with something ahead of time. If they've got a big wound that's spurting blood all over the place, I'm probably going to grab that first and put some pressure on it at the very least. But then in my mind, I'm still going ABCs as we go. So we're going to use that. We're going to try and use that same model to deal with another difficult disease of DKA. Okay, and thankfully, for my little mind, this is also broken down into just 3 letters that I got to remember: D, K, and A. So that's how we're going to remember how to treat DKA and in what order and what priority we need to. So I'll give you guys a second to think about the D as to what I might be referring to as a D as our #1 priority in DKA. This is always easier to do in person because you guys can yell things out, but I'll just move us along. So you've thought for a second about the D, and in this case, the D stands for dehydration. Okay, that's our #1. Oh, we had someone guessing, did we? Yeah, there we go. Yeah, you got it. Dehydration is the key. All right. So why do they get dehydrated? Well, this I stole from, this is actually a dialysis picture, or how dialysis works. But it's the same idea, and it gives a great picture, visual thing of what happens in DKA. You can see all the glucose molecules here on one side of the membrane. And in diabetes, as we know, the problem is there's no insulin. We want this glucose to spread across into the cell so that it has the metabolite it needs to make. And it should spread evenly. As all of you guys know, we like to keep things even, Steven. And so this should spread evenly over here. However, it can't get in without insulin. So all the glucose molecules are staying out here. Well, to keep the concentration even and similar, the water or the fluid starts to leave the cell, okay, to come and dilute out into the bloodstream instead. And once all that fluid comes out into the bloodstream, then there's too much fluid, it goes by your kidney collects it all, and there goes your polyuria, and eventually your dehydration of your entire system. So that's what's happening to cause that osmotic diuresis. So why is this so important? You can become profoundly dehydrated in DKA. You can be down 5 to 7 liters of fluid, a huge amount that can cause cardiovascular collapse, as well as other things. Okay, so this is the most important thing, and the thing that we can fix quickly, but not too quickly. Okay, so this is what I want you to remember: is we do need to fix that problem, and we do need to fix it quite aggressively. However, we can't be too aggressive. We have to have controlled rehydration. Why? Because of that same slide I showed you. Things are trying to even out, and if we sort of quickly change things and pound too much fluid in too fast, the fluid can again shift into places we don't want it to go. Most namely into our brain, and cause things like cerebral edema. So while we want to be aggressive, we have to be controlled in our rehydration. 2 large bore IVs, that's the mantra of every emerge doc, right? I want 2 large bore IVs on everybody. You stub your toe, come into my department, I want 2 large bore IVs. Not always possible. So trying to get that is the goal if we can. If not, especially again, if we're talking in rural places, you know, don't panic or think I need to get a central line. I haven't made a central line in forever. To be honest, an intraosseous line is better. Okay, easier to do, quicker to do. Can get fluid in faster than a central line. Not only faster, meaning it takes less time to get an intraosseous than it does a central line, but you can actually deliver more fluid through an intraosseous quicker than in a central line. And that has to do with physics and the whole thing. Someone enable closed captioning. Not sure what that means. Or I do know what it means, but not sure what I need to do with that. So yeah, make sure you get a line, if not get an intraosseous line, at least initially until they're more rehydrated and their veins are easier to find to get an IV. All right. So how are we going to go about rehydrating them? All right. So our first answer is always, I got my large bore IV, now I want to bolus, bolus, bolus. And really, I'm going to tell you that in this situation, unless they're unstable, you don't need to give a big bolus. So obviously, if they're super tachycardic and their pressure is nothing, you need to get some fluid into them. And that certainly warrants a 1, maybe a 2-liter bolus, but you want to be careful with this, okay? You just want to initially get some fluid in. If you do not consider them critically unstable, they are going to be tachycardic. Their blood pressure might be a little bit low, but if they're not critically unstable, it is better to give just aggressive rehydration versus boluses. Why? Because this is our number that we're going for. The ideal recommendation is no more than 50 cc's per kilogram in the first 4 hours of treating this. Okay, so if we use the textbook 70 kilogram male as being average, that's 3.5 liters in the first 4 hours. But remember, this includes pre-hospital fluid too. So if the medics have already bolused them a liter, that's 1 liter of your 3.5 liters already gone. And if you give them another bolus of a liter, that's 2 out of the 3.5 liters gone by. Okay, and so you got to be very careful. You got to include those in your calculations, trying to keep about that 50 cc's per kilogram in the first 4 hours total. Okay, so how are we going to start? Well, usually at about, depending on how sick they are and how big they are, about 250 to 500 cc's an hour. My initial order is 500 cc's an hour. Okay, to give them that fluid, get it started, and then we'll adjust as we go on. I'm just going to put this as a note, but I don't want you to pay much attention to it. This is more of an inpatient thing. Can consider switching to half normal saline if the sodium has corrected and that, but from an emerge department, or even if you wanted to just use normal saline going forward for the whole treatment, that is completely adequate. Got a question there. Normal saline. Yeah, we're giving normal saline in DKA, not ringers. Okay, ringers has made a comeback for a lot of things, and we're switching to ringers as being more isotonic and that for a lot of things. For right now, I would prefer that everybody uses normal saline because we're adding potassium to it. We're not giving it in a separate line. We have more control. It's as equal. There's no benefit to lactated ringers over normal saline, and it's much easier for us in this protocol. Hopefully that answers it for you, Lindsay. Okay, took away my surprise, but what's the K? Okay, well, it's a bit cheating here. I'm trying to jam this into a mnemonic that you guys can remember. But the K stands for potassium. We'll call it potassium if that makes it easier for you. So dehydration is our number one priority. Second is potassium. Okay. So again, I'm going to show you a diagram about potassium. Okay, so again, because we want to understand what's happening in DKA, that's the only way we're going to be able to treat it properly. So we saw the diagram of dehydration and why things move osmotically. It's because of the glucose, the osmos pulling them one way or the other. So how does potassium move in our body? Okay, so there's a few things here that you see. So here's the intracellular fluid and here's the extracellular fluid. So potassium can shift into the cells as needed by using insulin. Your body uses insulin as well as beta agonists. Both of those things can cause potassium to shift from the outside of the cell into the cell. That's one way it gets in. How does it get out? Well, it's things like hyperosmolarity and cell lysis causes the purge of potassium outside of the body. So that's how you lose potassium out of your intracellular fluid. And then over here is our potassium hydrogen pump, or hydrogen potassium pump, however you want to call it. And what that means is that there's an exchange often always going on in your body, and it exchanges hydrogen ions for potassium ions. If hydrogen's going in, potassium comes out. If potassium's going in, hydrogen comes out. It keeps it balanced. Okay? So those are three mechanisms of what happens. Okay, so I'm going to ask you to think about this for a second. In DKA, do you think the problem is too much potassium or too little potassium? Okay, in general, what is the problem in DKA? If that's our number 2 priority, what is the actual problem? Too little. Thank you, Richard. Yep, not enough, says Katie. Oh, you guys are bang on. I love it. I hate doing this virtually. I like doing it virtually because I can reach more of you, but I love having you guys yell that out at me, and that's great. You're exactly right, okay? These people are total body depleted of potassium, regardless what your lab test says. You might get a lab test that comes back and shows it's high. That's fine. It means it's high in the blood at this moment, but their body is depleted of potassium. Let's very quickly go back to this picture and let's say why. Why would your body be depleted of potassium? Well, everything that we just talked about is something that happens in DKA. Well, potassium moves from the bloodstream or extracellular fluid to intracellular by insulin. Well, we already know that we don't have insulin, okay, in this disease. So potassium is not going into the cell. That leaves it out in the blood, which leaves it privy to be removed by the kidneys and taken out. So we lose potassium. What pulls potassium out of the cells out into here? Well, hyperosmolarity. We already talked about that. We showed that picture with osmotic diuresis. We are hyperosmolar because of glucose being outside of the cell. So not only are we not bringing potassium into the cell where it's needed, we're kicking any potassium we have out. Okay, and again, that gets excreted in the urine. Here's the other big one, right? Sodium or the hydrogen potassium pump. So hydrogen is what makes acidosis. So we know we're acidotic. So there's a lot of hydrogen ions out here because we are at a low pH or an acidotic state. So what does it do? It goes into the cell, and that's a problem. It's a problem in and of itself, but it also kicks out the potassium. So for all of these reasons, we are continually losing potassium. Okay, so DKA has a shortage of potassium, end stop. Okay, and that is a potentially life-threatening complication. As you guys know, if there's not enough potassium in the bloodstream, the main organ that doesn't like that is your heart. Okay, the heart does not like hypokalemia. It doesn't like hyperkalemia either, but hypokalemia is lethal. Okay, so we need to replace though based on the serum level, which we'll talk about here. Okay, because you do get a serum level. But before we do that, remember our mantra that we were going with: airway, breathing, circulation, A before B, B before C. And we want to relate that to our new mnemonic of DKA. D is dehydration, second is potassium. However, D before K, all right? We want to make sure that we've dealt with the dehydration before the potassium, meaning we need to know that there is urine output. They have enough fluid for urine output before we start dumping potassium in. Why? Because if they're so dehydrated that their kidneys are not working and we start piling in potassium, we have no control over what's going on, okay? And we can go quickly swing from hypokalemic to hyperkalemic, not total body, but hyperkalemic in the blood, which again is potentially life-threatening to the heart. So we want to make sure that we see some urine output, or we know that they're peeing and that they're at least adequately hydrated before we start giving them potassium. The one exception to that is if you know that they are very hypokalemic, meaning if their serum potassium is less than 3, it actually says they're hypokalemic. They're even more hypokalemic than that, and they do need some potassium. And so if it's that low, we can start with some potassium. But again, we quickly want to see urine before we get too fancy with giving more potassium. And we are going to recheck the electrolytes every 2 to 4 hours to adjust the potassium concentration. Let's go look and see how we're going to adjust. So we are going to base, the one thing that we're stuck with is serum level. Okay, so we're going to get a serum level of potassium to tell us how much to give. Okay, I already mentioned that if it actually says they're hypokalemic in the blood, they are extremely hypokalemic. So we are going to add to our IV fluid, that sodium, normal sodium that we had going at 500 cc's an hour, we're going to add 40 milliequivalents of KCl. So your order is going to be IV normal saline with 40 milliequivalents of KCl at 500 cc's an hour. That's what's going in. If, however, your electrolytes come back and it says the potassium is normal, in a normal range, well, we all know it is not normal. It's normal in the bloodstream, but not normal in the cells. We're actually low. So we're still going to add potassium. We are going to use 20 milliequivalents in each liter of fluid, okay? If the potassium reads as high, which some of you have seen for sure, initially as all that potassium gets shoved out of the cell, through the hydrogen potassium pump and through hyperosmolarity, you can actually get a reading that's high, okay? Because all of it is in there and it hasn't been removed by the kidneys yet, but it will be. But at that case, because the level is high, we're not going to put potassium into the IV fluid until we get it back to a normal level, in the serum at least, and then we're going to quickly, this is why we're checking every 2 hours, because we are going to change the fluid depending on what the potassium says. If our next potassium, let's say it was super low and we had 40 milliequivalents per liter in there, if our next one comes in 2 to 4 hours and it's normal, we're going to take off that bag and replace it with an IV normal saline bag with only 20 milliequivalents. If it comes back as reading high, we're going to take off that bag and put on just normal saline until we get back into a normal potassium range. Again, we're rechecking every 2 to 4 hours. Any questions on that, guys? No? Okay. So take a second. DKA, dehydration, potassium. Just take a thought and think about what you think the A stands for in this case as our third priority in DKA. Couple of guesses. Acidosis, fantastic. Oh, sorry, I got, what am I doing here? All kinds of things here. So you're right, acidosis. I'm just showing this quickly. Again, if you're in a rural environment, you can't get electrolytes all that quickly. Some of you may have the ability on a VBG to get a point of care potassium. That's the ideal way of doing it. Most don't have that. So a quick and easy way to do it is to get an ECG, right? All DKA patients should be on the cardiac monitor or get an ECG as soon as possible to look for signs of extreme hypokalemia or extreme hyperkalemia. All right, acidosis and glucose. You can see that glucose is tagged on at the very end. It's not even part of the mnemonic, okay? Why? Because hyperglycemia is the least critical element here, guys. It is a thing that I worry the least about. I don't actually care about the glucose. It will correct over time. And as we go through our priorities, dehydration being number one, as we start to correct that dehydration, just purely by dilution, that glucose level is going to fall. Okay, so we are going to manage the glucose, but I'm not worried about the glucose per se. What I worry about, remember the very first picture I showed you, is the metabolism, right? The fact that our body doesn't have glucose to use, and so it's switched into an anaerobic metabolism, or a metabolism where it's breaking down fat and creating these ketone bodies that are a problem. That's my problem. Okay, so it is much more important to correct the acidosis, and to do that, we have to provide the body the substrate it's looking for, which is glucose. So I'm not worried about bringing the number of the glucose down. What I am interested in doing is bringing glucose into the cell so we can return to a normal metabolism and get rid of these ketone bodies and the keto acids that are the problem. Okay. And that's why acidosis is our concern, and much less so glucose. Okay. Now we have to be careful as we're doing this. The way that we're gonna fix this acidosis is to bring glucose into the cells, and we all know that that's where the insulin comes in. We've talked about it a number of times. The pathophysiology is that the problem is there's not enough insulin. But again, just like the fluid, where we like to be aggressive but controlled, we have to be the same here for a number of reasons. We can't drop the glucose too quickly. So we're looking for a reduction of only about 1 to 4 millimoles per liter an hour. That's what we're aiming for, is gradual. However, again, just like our ABCs, A before B, B before C. I know I'm repetitive, but that's the point. I'm trying to get this repetitive into your brain. D before K, K before A. Our first priority is dehydration. We're going to deal with that. Next is potassium, but we're not going to deal with that potassium until we know what it is, and we know that we've got a set of kidneys that works because they're hydrated correctly. How about K before A? Take a second to think, why would we worry about potassium before we worry about correcting this acidosis by using insulin to drag glucose into the cell? That's how we're correcting the acidosis, is providing the substrate, and we're going to use insulin. So what would the problem be with that? So the problem is the potassium, right? We've shown it already on a couple of slides. Insulin shifts potassium into the cell. Well, if you are hypokalemic already, and I now provide you insulin, I'm going to shift all the potassium into the cell. And what happens to your serum potassium number? It drops incredibly. Okay. And remember that ECG pattern in the cardiac when I showed you how dangerous that is. It causes cardiac problems if we suddenly go from a potassium of 3 to a potassium of 1. Okay. So we are not going to give insulin, and we're not going to worry about that acidosis until we know we have been correcting the potassium. Okay. Some of you might say, yeah, but it takes a while to get the potassium in my department. I've done an ECG and I know that we're probably okay, and I'm giving fluids. It might take me an hour before I give, or even more, to give that insulin then. And the answer to that is yes, I don't care. That's great. All right. This is the third and least important part to fix. Yes, we're going to get them insulin. Yes, we're going to correct that acidosis. Yes, we're going to pull glucose into the cells, but not at the risk of harming the patient by making them super hypokalemic. We want to know what the potassium is before we start the insulin. And yes, that might take time. And that's probably the biggest mind shift that takes people. We see DKA, we want to get insulin on, we want to start it right away and get it going. It can cause more harm than good if we haven't corrected the first two things. Vitally important for us to understand that. So if the potassium is less than 3.3 at any point through our treatment algorithm, we're going to, like we did in the last step, fix the IV fluids. We're going to increase the amount of potassium we're putting in. But we may actually stop the insulin for a while. We might hold the insulin drip until we've got that corrected again, because it must be corrected. Okay, otherwise we're going to run into life-threatening complications. We no longer give a bolus of insulin. It's not required. We started drip. The drip is 0.15 units per kilogram per hour as a start. Just to start. So 100 kilogram guy is usually somewhere up around 7-8 units per hour. And then we're going to titrate that every hour. Okay. Again, we're going to aim to reduce our glucose only 1 to 4 per hour. That's how fast we want it dropping. If it is dropping at that rate, excellent. Leave your insulin drip alone. If it is dropping, it's not dropping enough, there's no change in the insulin, in the glucose at all. In fact, the glucose is even rising. Well, then we're not going fast enough. The easy thing to do is just double the drip for the hour and recheck in an hour. If it's dropping too quickly, then cut the insulin drip in half. Okay, so it slows down. And this is what we do every hour. Again, this is a job mainly for the nurses, and it's a tough job, and it keeps constant watching and constant flow on both the electrolytes and the sugar to adjust these drips. But they're not too hard in that we're just doubling and half. Okay, for those, again, let's say we're out somewhere and we could not get my 2 large bore IVs. And you've maybe got an intraosseous line, I hope, because again, our most priority is the dehydration and getting fluids into them. But you're not sure or not used to an insulin drip, you can also give subcutaneous insulin. Okay, works just as well. It works in a similar fashion. There's no increase in complications and no increase in the time to resolution of DKA. So essentially, we came up with a 0.15 units per kilogram per hour of a drip. You can give that same amount as a sub-Q dose every hour. Okay. How about the use of bicarb to fix that acidosis? We get really antsy that their pH is down. We want to fix it. Bicarb is definitely controversial. Why? Because it has a risk. Okay. Again, remember that pH, the hydrogen potassium pump. If we fix that too quickly, we can cause a huge shift in potassium again, and it can go. But more importantly, it can cause what's called a CSF acidosis and delayed metabolic alkalosis. We really consider bicarb only after we have adequately fluid resuscitated them. We've given them enough fluid, we've got things on the go, and despite that, they're very resistant and they're staying severely acidotic. Their pH remains less than 7, even though you've got all the other things on the go. Then I would consider bicarb. But I would also make sure that my potassium, right? D before K, K before A, that my potassium is okay. Yes, Richard is saying it has to be rapid absorbing. Yeah, that's all we're talking about. So that's the same as the insulin drip. It's Humulin R. So that's what's going in your drip, and that's what's going as a sub-Q insulin dose is Humulin R. So yeah, we're only talking about rapid acting insulin. Okay. Here's the next part that sometimes gets us here and runs us into trouble. Is the insulin drip must continue after me telling you the acidosis is the least important part. It's the least important element to get to. But it is most important in that that's our guide to tell us whether or not we've returned to a correct metabolism. Well, are we back? Are we stopped? Have we stopped using fatty tissue to create our energy? Are we now fully back onto our proper metabolism? Your body is a very suspicious thing. And it does not believe, despite the fact you're now giving insulin, which is bringing glucose into the cells and your body is happily using that glucose, it's still suspicious. It thinks it's going to go away. It says, I'm not going to get fooled. You kept that sugar away from me for so long. I'm going to keep making these free fatty acids. So we need to be sure that the acidosis is corrected before we stop the insulin drip, not the glucose. Again, guys, we are not chasing the glucose number. The aim of DKA is not to normalize glucose. The aim of DKA is to stop the acidosis and to get us back onto a normal metabolism, as well as dealing with the hypercritical things of dehydration and potassium shifts. Okay, so we are going to be guided by their bicarbonate level and anion gap, not by their glucose. That's what's going to tell us when to stop. Okay. In fact, quite the opposite. We're not going to let their sugar get normal. All right. We are going to purposely keep them a little on the high side because we want to continue giving insulin and bringing glucose into the cells until the body has completely cleared away all of the bad free fatty acids and the bad things that it's done, and it has started to use a normal metabolism. And to keep giving that insulin, we actually have to provide glucose, because otherwise the patient eventually is going to become hypoglycemic if we don't actually give them sugar. Okay. So this, we use an arbitrary number of 12 to 14. There's nothing special or scientific about that number. Other than that, it's just a little on the high side. So it gives us a buffer and it lets us use. So once we get to that point of a sugar about 12 to 14, we are going to switch IV fluids to one that contains sugar. Okay. A little counterintuitive. You think, why would we be giving sugar to a hyperglycemic crisis? Well, this is why, because we want to continue with the insulin until the acidosis is done. So we don't want to deal with hypoglycemia. So we're going to give them sugar, same amount of potassium, same guidelines that we did previously about changing the fluid with the amount of potassium, but we're going to give sugar with it instead. And to give us that bit of a buffer, once we do that, we're going to drop the insulin drip initially by 50%, but then we're going to adjust it again. If the sugar's climbing again, we'll increase the insulin. If the sugar's dropping too fast, we'll decrease the insulin. If not, hopefully we're going to maintain. Okay, and we're going to continue that protocol for a few hours after we normalize. So once we see on our electrolytes that the bicarb is normal, the anion gap is normal, we're still going to continue for a couple of hours. We're going to let them eat and make sure they can keep eating. And we're even going to give them a dose of subcutaneous insulin, either what their normal dose would be or what you would normally give. And we're going to watch that and make sure everything is okay before we turn off the drip. We're going to keep monitoring ins and outs. We're going to watch our level of consciousness. We're going to keep looking at those anion gaps and lights every 2 hours. And we're going to remember to treat the precipitating illness. Okay, so don't forget about the precipitating illness. So a quick summary before we go to a few cases and any questions that you have. Okay, this is a difficult disease. I admit that. Okay, but those are the fun ones, right? That's why I love this disease. But the thing about any difficult disease, simplify, simplify, simplify your thinking. Okay. Talked about some of the world challenges, not, having familiarity with insulin drips, not being able to get an IV line, lights being difficult to get on a timely matter, using that ECG or cardiac monitors to at least guide you to the extremes to make sure that you know. Okay. Simplify your thinking. ABCs, DKA. Okay. We are all ingrained. Everybody knows what that ABC is, wherever you work in healthcare. Well, you should be the same with DKA. Dehydration, potassium, acidosis. Airway before breathing, breathing before circulation. Dehydration before potassium, potassium before acidosis. Okay. And for those that are working in a rural area, remembering to transfer these patients appropriately as you guys are able to or need to. It is not a question of ability, especially after hearing this talk and this great teaching that you just got. You guys know DK in and out, but as you know, it takes a lot of resources and a lot of manpower. And if you're working in a place with one nurse that's looking after everybody in the department and you and that nurse are delivering babies at the same time on a different floor, this is probably not the place for this patient, and consider transferring where we can monitor a little bit better. Any questions, guys, at this point?
Oh, you got a question in the chat box, and feel free to come off mute if you prefer.
Yeah, absolutely. You can talk as well. So does a DK order set in Connect Care match what is being presented here? It is very difficult to do that. And the short answer is no. And my request when they ask me is, I'm like, why can't you just put the paper copy in Connect Care? Because it flows well. We've been using it forever. It works great. And they tell me that it can't be done. And when I saw that, we only got we're in launch 5. We just got onto Connect Care. And when I actually saw it, I thought, oh my goodness, this is horrific. So we have made some changes, actually. I called them and we've made some changes already that went online, I think yesterday or the day before, to be a little bit better, but it's still difficult to do so. I'm always open to there. Are you using a provincial protocol? Yes. Yeah. the provincial protocol is based on my protocol that we brought in Red Deer, and that's how it got moved out and what they tried to model Connect Care on. But there is a way, and again, the most important thing to do is to learn how it goes so you understand that Connect Care. If we have a second, we're running out of time quickly, but I can try and log in on Connect Care and show it to you as we go through it here.
Yeah, I
Why don't
think
we do
another-
a couple?
oh.
Sure. Yeah, go ahead, Lindsay.
Sorry, it's Lindsay again. We've had 2 patients recently in DKA that were both quite hypothermic. Is that
Yeah.
something that we would typically see?
I don't know that we see
Or-
hypothermia per se, but that can either precipitate DKA or it can be a result of sepsis and other things. So again, number one, I would say you want to normalize as much as possible. So a bear hugger and warm blankets, obviously. Number two, make sure that you're looking at the cause of hypothermia. Why are they so hypothermic? So we all think about fever and sepsis, but remember they also can go the other way, and make sure you're not missing a sepsis. We treat thousands of DKAs, and I can tell you that's not a common presentation at all. You're just unlucky, I guess, Lindsay.
Okay, thank you.
Yeah. All right, well, let's maybe zip through a couple of cases here. And depending on if I get cut off or not, I'll log in. You can watch me clumsily log in on Connect Care. So episode 2, when DKA goes bad. When bad things happen to good people, and by good people, I'm referring to myself, of course. Why do these things happen to me all the time? Well, here you go. These are all somewhat real cases that have happened in our ED over the years, okay? So we have a 19-year-old male, known insulin-dependent diabetic, 3 days of nausea and vomiting, typical presentation. Mom thought he was just, had a flu, not feeling well, but today she had a hard time waking him up. And that's why she brought him to the ED. You can see his vital signs there. His chem strip is 26 and his breath smells funny. I don't know how many of you can actually smell ketones on the breath. I cannot. I also cannot smell different flavors on wine. My wife is good at that. She can tell what kind of wine it is by smelling. I just drink the stuff. Tastes good on the way down. So scenario 1 on this patient. So you guys say, yeah, you know what? We checked his chem strip. I can smell the ketones. This guy's in DKA. Let's go. Let's start treating it, okay? Nurses are doing their job, and I mentioned the things that we're watching. We're watching electrolytes, we're watching serum sugar, but you notice that progressively, he seems to be even drowsier. We're not improving here. He's even harder to wake up, okay? And then all of a sudden the patient has a seizure, okay, witness seizure. What do you guys think is going on? What should we consider here? What might have happened? What would have caused this patient maybe to have a seizure from our treatment? Any guesses?
Too quick of fluid resuscitation?
Absolutely, that's a possibility. So we talked about cerebral edema, right? So we went too much, too fast, okay? Sodium shift, says Richard. Yeah, that's certainly possible. We don't often see that, but it's certainly possible. That's a great guess. Common things being common, guys. His sugar. Did we go too quick, too fast? Okay. And he's hypoglycemic. We've all seen seizures from hypoglycemia, right? We didn't switch to D5, or we went too quick with the insulin and his sugar dropped. Okay. So the first thing I do when that happens and the sugar and everybody's panicking because he's having a seizure is I want a chem strip quickly. Someone grab a point of care thing. Let's take a look. Easy fix if it's too low, right? An AMPA D50 and you're back in the game. Okay. Otherwise, Lindsay, what you mentioned, right, is cerebral edema, too much fluid, too fast. Okay. And of course, we would then treat him for cerebral edema. But again, this is why this is not going to happen, because we are following our D before K, K before A protocol. We know that we're going to aggressively rehydrate, but not crazy. We're going to try and maintain that 50 cc's per kilogram in the first 4 hours so that we avoid a situation like this. Same patient, I told you that non-compliance is our biggest problem, and we often see the same patients over and over and over again. So the same patient comes in. This time we're ready for him. We're not going to give him too much fluid. We are watching his sugar carefully and making sure we're not being too aggressive with the insulin drip, and we're adjusting the insulin drip so we don't get hypoglycemic like we did potentially in the first time. This time we're going though, and man, this time he's really sick. Sometimes he comes in, he's early in DKA. He is really, really sick this time. So his ABG is there. And so we're getting things going, and we give him some bicarb, and we're talking about transferring this guy either to the ICU from my department or maybe from a rural department into us. And all of a sudden, he had him on the cardiac monitor. This happens. Very scary looking thing, and the patient's unresponsive to you. What's happening? What happened there? Quick guess. We're running out of time, so I'll tell you because you all know anyways. It's the potassium, right? Potassium. We were so worried about a pH of 6.6 that we rushed in to give him some bicarb before we followed D before K, K before A. What was his potassium? Well, his potassium was low, okay? And then we pumped in 2 more amps of bicarb, and we made him super low, which of course, like we mentioned, the heart does not like, and he goes into a hypokalemic cardiac arrest, okay? Follow the protocol, guys. Don't get tricked by numbers. Don't get tricked by what we think we need is important. D before K, K before A. This happens in our department all the time, where I'll call medicine and they come and they say, why hasn't he had bicarb yet? Because bicarb is badness unless we have fully resuscitated him, and that's our part. You can give bicarb after for sure, and that's their prerogative. But we are going to make sure as the initial treating physicians that D before K, K before A. We are going to try and normalize things first and get things on the right track before we do harm. Okay. Third time, this is a different patient, came transferred into us from peripheral hospital. He had presented in quite extremis. His heart rate was 130, his blood pressure was low. They did a fantastic job. They started fluids, with potassium, they knew his potassium level, started an insulin drip, they'd been titrating it down. Fantastic job, followed the protocol to a T, and everything is going smoothly. Called us to transfer, and we accepted the patient. This was the patient's ECG. As we mentioned, he's tachycardic, but the doc astutely noticed that not only is this just tachycardia, it's not sinus tachycardia, but he's actually an atrial fib with a rapid ventricular rate. And so for that reason, because he was in a rapid atrial fib, usually what he would do if that was a presentation is give a beta blocker to control the rate, okay? So that's what they did. They gave him some beta blockers on the way out the door coming to us. Well, by the time he got to us, he wasn't tachycardic anymore, but he was now crashing. His blood pressure was way down. His heart rate was way down. He had altered LOC. We ended up having to intubate the guy, central lines, and he eventually arrested. Why? Because of that beta blocker, okay? Remember that DKA is a high stress situation. We do want to treat the underlying cause, okay? But make sure that it's an underlying cause. Atrial fib doesn't typically put you into DKA. It's a result of DKA, or this patient had atrial fib. And our body is trying to compensate by increasing your heart rate. And if you take away that drive to compensate, then badness happens. It can't compensate cardiogenically, and that with its increased rate, and this patient ended up crashing. Fill the tank first, D before K, K before A. Before I'd worry about tachycardia and giving rate controlling medications, I'm going to control the rate by giving him fluids, by replenishing his fluids first as a reason to slow his heart rate down. Last scenario, IV fluids, potassium, insulin drip, all initiated, followed the protocol, adjusting Q1 to 2H. Despite all of what you're doing, his blood pressure remains low. His sugar's decreasing, but he still remains acidotic, and his anion gap stays high. What do you think might be happening here? I'm even going to tell you, maybe, Lindsay, that he's shivering and he's maybe even hypothermic.
He's septic.
He's septic. Yeah, there you go. So make sure, often this is forgot. We get so wrapped up in the DKA part of it, we forget about what is the cause, and sepsis is a major cause of DKA. So we did all the right things from a DKA point of view. We've done everything in order, D before K, K before A, fixed all of that. However, he continues to get sick. Why? Because we ignored the precipitating cause, which was sepsis, okay? His lactic acid is going up, and that's why he remains acidotic, and why his anion gap is going up, because we're getting rid of ketones, but we're adding lactate, okay? he needs antibiotics and pressors and treatment of that protocol. Another question. Okay, yeah, thank you. Yeah, we're out of time, guys, I think, unfortunately, so I can't go through the Connect Care. I'm happy to do this again sometime. And you guys can, oh, there you go, perfect. Is that the protocol? I don't know. This is the provincial knowledge topic, yeah. Let's do.
There should also be a order set too that was put out.
Yeah, this is it that you guys should get. This has slightly changed in the last couple of weeks. I added some things. Or we arranged some things, but I'll show it to you in general. This is the order set, the paper order set that looks somewhat like Connect Care. Or they're trying to make the Connect Care look like it. But again, this stuff we'll skip, but this is the routine stuff that's on there at the beginning of that complicated thing, lab work, all of that. I'm going to get down to the treatment one just very quickly. Okay. So this is how we've laid it out, exactly as I've described it to you here.
We just see our PowerPoint still.
Oh, you do?
Sorry, yeah.
Oh. Okay, let's, I want to share my screen though. Let's see. So share screen. How about that? Can you see that now?
Yeah.
Yeah, perfect. Okay, so this is the paper order set, which again, Connect Care should follow shortly or try to follow. Again, we'll skip all this stuff as the initial lab work and all of that. Let's get down to here. So it's laid out how I talked to you guys about D, K, and then A. So here we go, intravenous orders, initial resuscitation. If you believe they're in severe dehydration or hypovolemic shock, then go ahead and bolus them, okay? Over an hour, over how many minutes you want, but it's not a given. For the most of the rest of them, we're gonna start at just 500 cc's an hour of normal saline, okay? No potassium, no nothing, because we don't know what it is. We're just giving them fluid, we're giving the dehydration part, okay? That's the initial order. Now, once we confirm it's DKA and we've got more information, okay? Now that we've got more information, now we're gonna give these intravenous fluids. We're gonna go, again, you're gonna judge basically whether you wanna go at 500 cc's an hour and 250 cc's an hour. I mentioned this half normal saline. Again, that's for specific things and often it's the internist that does it. We have removed this from the eMERGE protocol. Just so that you don't get confused. So this is no longer an option because I don't want you considering it. It's just this. And based on how dehydrated they are and how big they are, you're going to say at 500 or 250 cc's an hour of normal saline with potassium on the separate order. So again, this potassium is given only if, and there's new wording in here that says only once you know what the potassium is, okay? So again, if the potassium, and this has been changed to the numbers I told you, it's 5 to match the inpatient set. But if it's greater than 5, it's going to say greater than 5 or high, don't put potassium in the fluid. If it's normal, you're going to add 20 millimoles in each bag. If it's less than 3.3, that means they're really low, you're going to add 40 millimoles. I know that you're going to say peripherally, they can only get 20 an hour. Well, you're only giving it at 500 an hour. There's 40 in the bag, and the highest you're giving it at is 500 an hour, which is 20 an hour. So it meets your provincial guidelines as giving potassium peripherally. Then we go on to the insulin orders. Again, it's hard checked to hold the insulin if the potassium is less than 3.3, and now it will say or unknown, meaning that you have not yet got your potassium yet. So it'll say a hard stop to hold insulin when potassium less than 3.3 or unknown, okay? And to notify us if the potassium is less than 7. Again, regular insulin, 0.515 units per hour. Your doc's gonna write in a dose. Again, if it fails, if it decreases by 1 to 4, we're bang on. If it's not decreasing enough, we're gonna double the rate. If it is decreasing too fast, we're going to reduce by half, okay? Once we get to less than 14 for 2 consecutive readings, we're gonna change the IV to D5 half normal saline. So this is for glucose less than 14. Still gonna use the potassium, same potassium regulations, okay? We've decreased insulin by half previously, and we're going to use this new scale to adjust it. We want to keep it in that 12 to 14 range. That's our goal, is we're keeping, and that's what this is designed for. We're going to maintain that IV insulin until the acidosis is resolved. That means normal pH, normal anion gap, and a bicarb greater than 20. We're not going to stop it because the sugar is low. If the sugar is low, we are going to increase the sugar that we give. This is older, guys. There's newer and better documentation on the newer one, but I just wanted to show you this quickly. I know we're out of time. But you can see that the protocol is based on the way you should be thinking. Step by step and in that order. That's how I laid out the protocol, is for you to think the way I think. Not that that's a good thing all the time, but in that order of things that you need and how you're going to do it. Any quick questions, guys, before I got to let you go? Is that the new Jody? Is that I don't know what that is, but any quick questions, guys? Nope. Okay, great. Thank you very much. Gonna get rid of all of that. Thanks for your time. Hope that made sense. Let me know if there are any other questions that you have.
Thank you so much,
Great.
Dr. Thomas. Really appreciate it. And the
Thanks.
recording will be on the CNE channel for you by the end of the day. If anyone would like to replay.
Great. Thanks again.
So thanks for joining. Have a great day, everyone.